In this study, we will explore if unnoticed and continuous urinary incontinence patterns have different clinical and/or urodynamic characteristics. We have nothing to disclose. As we mentioned in our previous work, according to the symptom profile, incontinence can be classified into three main patterns: stress, urgency, and mixed. The most prevalent type is stress incontinence, then mixed, and finally urgency. However, other types of incontinence have been found to be very prevalent too. In this analysis of the EpiLUTS study, where 30,000 men and women were surveyed about the LUTS, they found that 15.6% of women had other types of incontinence, usually combined with stress, urgency, or mixed incontinence. These other types of incontinence included post-micturition, coital, nocturnal, or leakage for no reason. The interesting point is that women who combine these other types of incontinence with stress, urgency, or mixed had worse physical health and more comorbidities. Moreover, anxiety and depression were more prevalent too. Another type of incontinence is continuous leakage. This type of incontinence is not included in the previous study. It is defined as a complaint of continuous involuntary loss of urine which may be caused by sphincter abnormalities or extraurethral incontinence. It's considered a complicated type of incontinence. In our previous work, we found that women who combine stress, urgency, or mixed incontinence with leakage for no reason or continuous leakage in the self-diagnostic item of the ICIQ-UI short form had a greater amount and more frequent incontinence, as well as a greater impact in quality of life. These incontinence patterns were denominated complex patterns. In this work, we will search for differences in bladder diary and urodynamic variables between simple and complex patterns. We conducted a retrospective cross-sectional study from a urodynamic database in which we included women who claimed to have stress, urgency, or mixed incontinence in the ICIQ-UI short form. We excluded patients with neurological conditions. We further classified patients as having complex incontinence if they leaked for no reason and/or all the time. We compared 3-day bladder diary and urodynamic variables between simple and complex patterns. The ICIQ-UI short form is a questionnaire for the evaluation of the frequency and amount of urinary incontinence and its impact in quality of life. It also has a self-diagnostic item about the circumstances in which the leakage happens, which let us define the different patterns like stress, urgency, nocturnal, post-micturition, unnoticed, or continuous incontinence. We included a total of 293 women with a median age of 62 years within a range of 10 to 90. The distribution of patterns is as follows. 62 patients had stress incontinence, 14 of which were complex. 75 had urgency incontinence, 18 of which were complex. 156 had mixed incontinence, 19 of which were complex. Therefore, 58.3% had simple patterns and 41.6% had complex patterns. Although in our previous work we found that total score and subscores of the questionnaire were significantly higher for complex patterns, we couldn't find any differences in bladder diary variables in the stress incontinence group, but we found differences in the urgency and urgency incontinence episodes between simple and complex patterns in the urgency group and mixed incontinence group. We also found differences in the number of pads in the mixed incontinence group. When we compared urodynamic variables, we only found that simple patterns taken as a whole had a greater detrusor pressure than complex patterns. So our interpretation of the results is that there are only minor differences in the 3-day bladder diary and urodynamic variables between women with stress, urgency, or mixed incontinence who also leak for no reason or all the time. Therefore, our concluding message is that we could not demonstrate that complex incontinence patterns have different pathophysiological mechanisms.